Hello everyone, greetings and best wishes from the University of Missouri in Columbia, Missouri from the United States. I wish I were there today, but extraneous circumstances did not allow me to be there with all of you. But modern technology is so fantastic. The difference between real presence and virtual presence has blurred. So think that I'm there with you today. Before I begin my lecture today, I would like to thank Professor Irsa, Dr. Amal, for inviting me to be delivering this lecture, this inaugural lecture to all of you today. And indeed, it is a pleasure that I'm able to discuss with you over the next 45 minutes or so on the importance, on the realms of green nanotechnology in nuclear medicine. In fact, you will be hearing a lot more about the production aspects of the radioactive gold nanoparticles, which I'll be discussing. And those production aspects will be handled by a very able scientist, Dr. Amal, who was one of our very best students here at the University of Missouri, who did the production of these radioactive nanoparticles, understood their stabilization, their dosimetry, all of that you're going to hear from Amal, who has gained tremendous expertise in this nanotherapeutic radiopharmaceuticals. So my plan today, as you see on this slide, is basically giving you a bit of introduction about ionizing radiation. You're all experts in the subject area, and the overall broad applications and the focus of this meeting, which I just now stated, is about harnessing the power of radioactive materials in medicine. And then I will show you how nanotechnology, how important this disruptive science, we call it as, how important this disruptive science is in the realm of modern medicine. Then we'll make some recommendations on how we can together address eradicating, alleviating pain and sufferings of human patients suffering from this deadly disease, what we refer to as cancer. Yeah, we always start with neutral atoms. When you're talking about radioactive atoms, you start with neutral atoms. Irradiations will give you different types of metallic isotopes. All of us are aware. Some of the isotopes emit imageable radiation, and gamma radiation is widely used. There are varieties of isotopes, technetium for SPECT, copper for PET, and varieties of other PET and SPECT and PET isotopes are there. And this is just to remind us that when we are talking about radioactivity, it is not just the betas, the gammas make a significant contribution to nuclear medicine. So here are radiations that penetrate the tumor mass, that penetrate the tumor cells, tumor vasculature, alpha radiation, beta radiation, gammas and X-rays, and of course neutrons. So today I will be confining myself with the beta radiation, because the subject matter of today's discussions are how do we harness the radiative emissions of radioactive gold nanoparticles. There is something unique about this metal. We're going to address that. Before I do that, just a quick introduction about my institution. About 6,000 miles away, here we are in the heart of the Midwest. Just so that we all recognize, 2018, one of our colleagues won a Nobel Prize in chemistry. Columbia, Missouri used to be a flyover zone for a number of years. We have almost instantly become a landing zone. So we are of course we have been globally recognized for a number of things that we do here through the med school, through School of Journalism, largest university-owned nuclear reactor, and many great things. There was one thing that was missing, which was the Nobel Prize, so it's a full circle. So one of our colleagues, George Smith, won this Nobel Prize. So we have instantly, as I said, become a landing zone. So my own department has pioneered development of varieties of cancer diagnostic and cancer therapy agents using radio probes. Many of you know Therapeutic, which is the first metal-based blood-brain barrier penetrating brain imaging agent, which was developed here at the University of Missouri, then licensed to a corporation. Then later we developed a bone palliation agent, Quadramat, again licensed to a corporation for human use. All are FDA approved. And then TheraSphere is a microsphere-based radiopharmaceutical. When injected in the hepatic arteries, does spectacularly well in treating hepatic tumors. So, just so that you know, you will be hearing a lot about nanotechnology, green nanotechnology in my presentation today. It's important to connect here that my institution was talking about reducing the sizes of radiopharmaceuticals to be able to achieve better therapeutic efficacy. So, we are talking about microspheres way before the rest of the world was even thinking about applying nanotechnology to medicine. So, some nice connectivity there. So, the rest of these application of gold nanoparticles to medicine is something that you are going to hear about today. In case if you are wondering the power of a nuclear reactor, I just now stated that we own the world's largest university-owned nuclear reactor. It operates under these conditions. It's a 10 megawatt. It is we have the relicensing for this, and it has lots of great things going on. We produce practically almost every therapeutic isotope used in nuclear medicine. Just a few more things, beautiful blue glow of the reactor. Amal, who is within the audience today, has worked in the nuclear reactor, produced radioactive gold nanoparticles. I'm sure she recognizes the tremendous value this capacity infrastructure brings not just to my institution, to the entire US and perhaps to the whole world in terms of our continued quest to treat cancer patients. The focus is going to be on cancer. The reasons are obvious. These are the statistics. No matter what journal, what publication, news media you think about, you see about, you will see these daunting statistics. Cancer continues to kill more lives compared to many other diseases put together. The prognosis is very bleak. The cancer incidence, the cancer death is going to increase precipitously over the next 15-20 years. Varieties of reasons are there. It's beyond the scope of the meeting to discuss the reasons, but this is a collective responsibility. This is not a disease that affects me. This is not a disease affects some of you. It's a disease affecting our entire planet. Our brothers, relatives, neighbors, friends, everybody in one way or the other are getting affected with this disease. We spend tremendously large sums of money. It's actually called as an economic killer because it takes away almost 1 to 1.5% of GDP of the whole planet. So, this is a big problem. So, we need to solve this problem collectively. In case if you are wondering what are the types of tumors that that is inflicting the human civilization, varieties of tumors, prostate tumor, breast tumor, pancreatic tumor, glioblastoma. It just depends where you live, what kind of environment you are in, what kind of genetic makeup you have, but it continues to affect all of us. There are many examples. The statistics is there for all of you to look at. Again, more statistics here. So, the next question has to be, what is it that's evading all of us? Why are we not able to discover effective drugs to treat this disease? The challenges are very many. It's a moving target. If we discovered a drug for prostate cancer, maybe for the early stage, that drug may not work for a late stage of the disease. That applies to varieties of other tumors. So, it's a very complicated disease, requires a concerted collective effort because this disease doesn't depend on one cytokine, it doesn't depend on one functionality, it depends on many factors. No wonder this disease continues to invade human population, destroy our productivity, take away large sum of the gross domestic product of this world. So, the main problems that continue to haunt us are currently available pharmaceuticals or radiopharmaceuticals, they don't spend enough time. They are not taken up in optimum doses within the tumor sites. That's one of the main problems. Then if they go and localize within the tumor, they don't spend enough time to be able to destroy the disease, to be able to shrink the disease, to be able to control the disease. That's another problem. Then inability to target macrophages, something I'm going to address very briefly in this lecture, although it's way beyond the scope of today's lecture. Macrophages, for those of you who are not into tumor biology, think about driving a car without a machine. You will not be able to drive the car. You can have the best body, best tires, best color, so forth. If you don't have the machine, you will not be able to drive the car. In the context of cancers, any cancer for that matter, macrophages are the engine of all cancers. If your drug doesn't take out that engine, cancer continues to grow. So if somebody tells you that here is a drug that treats cancers, but it doesn't target the macrophage, we should not believe that that drug is going to make any difference in the lives of human patients. That's where macrophage targeting drugs have become extremely important pharmaceuticals in the 21st century. And then we need to be addressing collectively, because this is a meeting that's about using radioprobes for cancer and other diseases. One of the disadvantages of radioprobes is that while it tries to treat tumors, it also makes the disease resistant to treatment. That's one of the disadvantages of this therapy. That's where we need to be collectively working. Again, this slide summarizes what all I said just now. Tumor is a very smart disease. We hate to admit that. It's smart because it has self-sufficiency. It grows uncontrollably. Insensitivity to anti-growth signals. That's one of the hallmarks of most of the tumors. Tissue invasion and metastasis. There are many, many aspects. Limitless replication potential. Sustained angiogenesis. Can we design a drug that takes care of all of this? The answer lies in how effectively we can put different types of cancer therapeutics into one under one roof or into one patient. Current treatments, again, let's look at, we have surgical methods. If a tumor is growing rapidly, if it's a solid tumor, our surgeons are efficient, whether you're in Iraq or India or China or Europe. We have very effective surgeons. They cut open the body, surgically resect the tumor. That's one way. Okay, that still doesn't guarantee the metastasis, those cancer cells hanging around the body in the blood. Chemotherapeutic drugs, they tend to be non-specific, but they can treat. They can do so much to elongate the lives. Still, it's an unfinished job. We have the targeted therapies. We have non-specific radiotherapies. There are varieties of techniques already available. That's why we save quite a few lives. But the business is not done yet because the disease continues to kill patients. So the proof is in the pudding that cancer appears to be killing lots and lots of patients despite many, many discoveries that we continue to unravel. Treatment options for prostate cancer. Why am I jumping to prostate cancer? I'm just taking one example. Advanced stages of prostate cancer, unfortunately, if you declare yourself as a male human being, the bad news is we have no escape from prostate cancer. Every male human being will suffer from prostate cancer. The good news is every male human being will not die out of prostate cancer. Okay, but if left untreated, if left undiagnosed, it can metastasize to other organs, bringing down the quality of life, and in many instances patients do die. So that's why I'm taking this as an example, how we can use emerging technologies to treat prostate cancer, and what we learn out of this disease, out of this modality, is applicable to many other types of cancers, including breast, pancreatic, glioblastoma, and so forth. That's what you will see today. Again, as I said, these are the various treatment options we have, but still we are not able to control, address advanced stages of prostate cancer, which we normally refer it as androgen independent stage of the disease. The disease becomes independent of the hormone. So, your hormone targeting drugs will not treat prostate cancer at advanced stages. Let's talk about what is the big deal about nanotechnology. Globally, governments, private corporations, foundations are investing millions of dollars in applying the principles of nanotechnology to medicine. That's something we are going to discuss. Nanoparticles have the ability, they can directly target the tumor cells because there is a size correlationship. Nanoparticles can provide improved biodistribution. They can enhance the pharmacokinetics and pharmacodynamics. Nanoparticles allow us to deliver diagnostic probes and therapeutic probes in a singular pharmaceutical. That sounds like a fairy tale, but you're going to see some fantastic proofs how nanotechnology can revolutionize medicine, how it can bring a paradigm shift in the way the oncologists would start treating patients. There are varieties of nanoparticles. I'm sure people are using different types of nanoparticles. Within this conference, I'm sure you have research going on with carbon nanoparticles, varieties of nanoshells, nanorods, nanospheres. So, I'm going to be addressing today on our discovery which we jointly made with Dr. Amal, who is in the audience, about gold nanoparticles, about radioactive gold nanoparticles, and about these particles, how they are, they can be made tumor specific, how we can give these nanoparticles a sense of direction once they are in the body, how can we make them target the tumor sites. All of that we are going to discuss today and see how effective they can be in treating varieties of cancers. Radioactive gold, as many of you know, gold metal has two distinct isotopes, gold 198 and 199. They can both be produced in the nuclear reactor. I know Amal is smiling now. She actually led the efforts in my program to produce radioactive gold 198, stabilize the isotope, and use it for investigations related to testing the efficacy of this nanoparticulate agent for tumor therapy. Her entire thesis is focused on production of radioactive gold nanoparticles and using these nanoparticles for tumor therapy. It's a great thesis. Again, congratulations, Amal. So, these particles, let me go back, they have one of the beauties of this isotope, as you can see from the radiochemical properties. This isotope has gamma emission, ideal for imaging, ideal for SPECT imaging, ideal for scintigraphic imaging. This isotope also gives us the ability to destroy the tumors because it has the beta energetics ideal for tumor cell killing. That's why in the singular treatment, now we have that opportunity. A single injection could do both the diagnostics and therapy. Think about it. Have you heard a drug in the form of a pill, if you take it, it does both the diagnosis and therapy? People would have told us that this is a laughing stock if we had discussed this 5-10 years ago. Not anymore. With nanotechnology, we can develop drugs that do this dual diagnosis and therapy function within the same dose. And we have coined a new terminology for that, diagnostics and therapeutics. We are calling such agents as theranostics. So, gold 198, gold 199 qualified to be great theranostic agents for diagnosing and treating cancers. So, let's talk about the production. This is an area, again, I want to emphasize here. Dr. Amal, in her workshop talk, she is going to provide full details. So, I am not going to take away her slides. I am just giving a glimpse of the production so that I can continue on the discussions about the importance of these nanoparticles in terms of their targeting ability to different types of tumors. And synthesis is done by a very interesting method, which we invented several years ago. We are not using any toxic chemicals here to produce gold nanoparticles. We are using phytochemicals that are there in the plants. Why do we use them? These phytochemicals are rich in electrons. Any process that aims to produce gold nanoparticles that process must inject electrons into a gold precursor. So this is where we made an invention that because these phytochemicals from plants, phytochemicals from soya, from tea, cinnamon, clove, mango, they all contain lots of electrons. They are reservoirs of electrons. So by mixing those phytochemicals with the gold precursor, we demonstrated to the world that we can produce well-defined nanoparticles. This was not just a scientific curiosity. Now we are able to make these nanoparticles at large industrial scales. So this works. That's another aspect of Amal's thesis, where she really showed that this, in this case, it is a mangiferin, a phytochemical from mango, when mixed with gold precursor, produced well-defined nanoparticles, and the constitution of these nanoparticles is based on the ability of this phytochemical not only to produce nanoparticles, the ability of this chemical to stabilize these nanoparticles. Because as many of you know, once you produce these nanoparticles, the surface atoms are extremely reactive. If you are careless in stabilizing these nanoparticles, they would agglomerate. As they agglomerate, they obliterate the nanoparticulate property. So in nanotechnology, when it comes to medical applications, synthesis is only one part. Stabilizing them and making them stable under in vitro, in vivo profiles is of paramount importance. That is something we are able to achieve by this phytochemical. It does dual roles of production and stabilization. We used varieties of phytochemicals. We have published immensely in this field, as stated, and the constitution looks like this. You have a monolayer, bilayer, trilayers, so that the phytochemicals, once they are encapsulated around gold nanoparticles, they remain bound to the nanoparticles. They are not easily metabolized in the body, because we want these phytochemicals to stick to the nanoparticulate surface when these nanoparticles are in the body, because these phytochemicals have both the targeting ability as well as the therapeutic capabilities. That's why we want them to be stuck to the nanoparticles. Then it's a synergistic effect of the nanoparticle along with these phytochemicals to go and interact with the tumor cells. So it's a very interesting, all these processes occur in tandem. It is not stepwise, it's all happening in tandem, and the net effect is we're able to control and destroy the tumor cells. So for those of you who are wondering what's going on here, the pharmaceutical, the nanoradiopharmaceutical. Nanoradiopharmaceutical would look like this. You have the gold nanoparticles, radioactive gold nanoparticles, because you have the gamma and the beta. You have lots of goodies here, lots of great things happening here. The emission is not just the beta. It has, through the Compton effect, you have the OJ electrons, you have the photoelectric electrons, and then you have the X-rays. So all this good electron cloud is going to burst, is going to interact with the tumor cells. Again, the net result, our whole idea is to destroy the tumor cells completely, so that we can bring that benefit to the patient community. This is how the therapeutics are going to look like, and some examples I'm going to provide. We started with this phytochemical a long time ago. It is the epigallocatechin gallate. At the end of the conference, I'm going to have Amal test all of you. You need to pronounce epigallocatechin gallate. You're all going to get an A grade if you can pronounce that. So this phytochemical, again rich in electrons, interacts with the gold precursor, produces nanoparticles, also encapsulates around the nanoparticles. And we translated that with radioactive gold, produced epigallocatechin gallate encapsulated nanoparticles. The size is important. The tumor cells are 10 to 15 microns in size. If the radiopharmaceutical is larger than a tumor cell, then we have no chance to penetrate the tumor vasculature, tumor cell vasculature. That's why nanotechnology is a boon in terms of our ability to target individual tumor cells. We got to target individual tumor cells because tumors don't grow out of the tumor tissue. Tumors grow and metastasize and proliferate through the cellular form. So if we don't target the cells, we have no chance to treating this disease. That's where the size is important. That's where the nanotechnology intervention is extremely important in tumor diagnosis and therapy. So now we have achieved the correct size. then this is how it's going to look like. If this is the tumor, the vasculature allows any drug, any particle less than 350 nanometers can penetrate the tumor vasculature. Our particles are way less, way lower in size than the 350 nanometers. That's why they're able to penetrate the tumor vasculature. Of course, crossfire effects are all important. We have considered that in our dosimetric calculation. Amal recently published a paper in one of the top journals. She will discuss that, where we understood all these crossfire effects in order to enhance the biological effective dose to the tumor site. So we have considered that aspect very well. This is not a cartoon. This is what happens when we mixed these radioactive nanoparticles, particles encapsulated with the tumor-specific phytochemicals with prostate tumor cells of human origin. You have so many nanoparticles per cell. The picture what you are seeing here is one human prostate tumor cell mixed with this therapeutic gold nanoparticles. You have hundreds of nanoparticles per cell. This gives an oncologist that luxury to modulate the dose. You don't need so many nanoparticles per cell. We need very few nanoparticles per cell to destroy the cells. That means that we can inject so much less and still see outstanding therapeutic efficacy. Administering lower doses is important because we want to minimize the collateral damage to the rest of the normal cells, rest of the human body. If you can administer a dose that is effective to destroy the tumor, a dose that doesn't affect the normal cells, that is the holy grail in oncology. And nanotechnology has that potential to address that. We have done all the biochemistry. What you're thinking about, are these tumor cells, are these gold nanoparticles tumor specific? And how do we know that? Okay, it's one thing to imagine that we want to develop therapeutic drugs that are tumor specific, that won't target the normal cells. It's a whole different ball game to show step by step different methodologies, different tumor biological techniques that we have used to demonstrate that these nanoparticles encapsulated with different phytochemicals, which include epigallocatechin gallate, mangiferin, which you will see in a moment, they're all tumor specific. It's not by accident. We have analyzed all of that by neutron activation analysis, by doing blocking experiments, by doing everything what it takes to demonstrate through tumor biological techniques. Picture is worth 1,000 words. This is one of the very best textbook examples. As you see here, this is what happens when we injected these nanoparticles within the prostate tumors in dogs. Why did we use dogs? Dogs' prostate tumor mimics human prostate tumor in terms of the tumor morphology, tumor genetics. There's a one-on-one match. If you're wondering what are those animal populations which get spontaneous prostate cancer, you guessed it right. Male human patients, male human beings, and the dogs. No other animal in the animal kingdom, in the mammalian kingdom, gets prostate cancer spontaneously. So FDA requires us to demonstrate the efficacy of any new experimental drug in dogs' prostate tumor first before getting into humans. That's exactly what we have done here. That this slide shows the power of the theranostic agent what we have developed. This is the site of the injection. I can clearly see how the radioactivity is residing within the tumor site. Is the radioactivity leaking out through lymphatic drainage? I can see there is no lymphatic drainage, as you can see here. 30 minutes, 1 hour, 4 hours, 24 hours, the radioactivity resides within the tumor. In one injection, I am able to see the radiation dose. At the same time, that radiation dose is also delivering biological effective dose to destroy the tumor. That's what you will see on the next slide. This is the radiation dose sticking to the tumor, minimal or no lymphatic drainage. That means that the drug is not interacting with the rest of the body at all. All of the activity is within the tumor. This order of specificity of a tumor drug is unprecedented. Most of the cancer drugs, oncologists would be happy if they see 5–10% of the injected dose residing in the tumor. Here you are seeing 85–90% of the injected dose residing in the tumor. That's why I used that adjective. It is unprecedented. Literally, it is unprecedented to see this order of selectivity of any cancer drug towards the tumors. And that translated into spectacular therapeutic efficacy. As you can see here, these are the animals with the control group of animals which did not receive our drug, radioactive gold nanoparticles. These groups of animals are the animals which received just about 0.136 microcuries. It's not a whole lot of activity. You don't need to give that much because the drug resides within the tumor. There's just an outlier here, which is good. Sometimes when you're doing an experiment, one of that animal had a genetic makeup. It didn't respond to that tumor treatment, which is fine. But overall, we saw 85 to 90% reduction in the tumor volume, something spectacular. This we wish we can quickly translate into human patients. That is something we are working actually. Another example, you might say, oh, Kattesh, this is an isolated case. Does it really work with other phytochemicals? That's an important question. Before you could ask us, we asked that question. And here are some of those experiments. We chose this phytochemical, mangiferin, again from the plant source. The beauty of this phytochemical compared to epigallocatechin gallate, both of them have polyphenols, but this phytochemical has the glucose. As you know, through Warburg effect, tumor cells metabolize glucose extremely rapidly. That means that if I attached my radioactive gold nanoparticles with this phytochemical and then introduced that into the human patient, the odds of seeing radioactive nanoparticles encapsulated with this drug within the tumor sites will go up precipitously because tumor cells love this glucose. They think that this is something I need to have, I need to grab. That's exactly what we saw in our studies. First, we had to produce the particles through our technique of green nanotechnology. I call it as green nanotechnology because everything what we do is literally green. The source of the phytochemical is from the green source from plants. We don't use organic chemical per se here. We don't even use alcohol in our pharmaceutical constitution. Interacts with the gold precursor, produces these radioactive nanoparticles encapsulated with this phytochemical. Now, all the characterization, everything, Amal is going to spend quite a bit of time in her lecture about how she went about translating this science to produce the radioactive analog. I'm not going to spend too much time here. As I said, I'm not going to steal away her slides. Something great is there in her lecture. Make sure that you don't miss her lecture. So, we replicated that process with the radioactive gold nanoparticles, and then the same thing when we incubated those particles with this prostate tumor cells, we saw hundreds of nanoparticles per cell. Their affinity to the tumor cell is simply unprecedented. They go into the tumor cell not by accident, they go into the tumor cell because there are laminin receptors overexpressed on these tumor cells, and mangiferin as well as epigallocatechin gallate, they have predefined affinity to the laminin receptors. So, if I am able to attach these laminin receptor specific phytochemicals to my gold nanoparticles, I can see enhanced efficacy of internalization or endocytosis of these nanoparticles, and that is exactly what you are seeing here. So, again, the size is important. We have kept the size to such levels to be able to penetrate the tumor vasculature, and as I said, picture is worth 1,000 words here. What you are seeing here is internalization of nanoparticles into tumor cells. Beautiful golden colored dots, what you see, they are all gold nanoparticles getting into individual tumor cells. Every prostate tumor cells has an effective number of these nanoparticles, which means that those nanoparticles, once they start emitting their beta radiation, they would decimate, destroy those nanoparticles. And this is a control group of prostate tumor cells. Again, I don't want to spend too much time here. We have done extensive studies to demonstrate what you are seeing here is not an accidental internalization. What you are seeing here is the effect of what we have encapsulated, mangiferin, its effect to target the tumor cells through receptor specific interaction. It's actually called as receptor mediated endocytosis. How do I know that? When we block those receptors and mixed with these gold nanoparticles, we did not see these particles getting into the tumor cells. That's why we conclude that everything what you're seeing here is receptor specific. Any human patient who has laminin receptor positive cancer, which includes prostate cancer, pancreatic cancer, lung cancer, hepatic tumors, these nanoparticles will find an application both for diagnosis and therapy. And that's the focus of this meeting. How do we digitalize? How do we develop these new technologies, new particles that are tumor specific? Here is that example which really focuses on the overall focus of this meeting. Again, these particles are tumor specific, as you had seen with the epigallocatechin and gallate nanoparticles. Very limited or no lymphatic drainage that translated into really spectacular therapeutic efficacy curves. Something I need to tell here, Amal, when she was doing PhD with me, she performed many of these experiments, and then she brought me these therapeutic curves. This is the control. Of course, the tumors keep growing. Many animals get ulcerated. Unfortunately, we had to compromise those animals according to animal protocols because we don't want to see animals suffering. But these animals which got certain amount of the radioactive nanoparticles, as you see, there is absolutely no growth of the tumors. Amal did what you are seeing here, the yellow one first. Then I told Amal, this looks unreal. Can we regrow the tumors in a different set of animals and redo it? Because if I showed this to the scientific audience in the world, they would ask me, this doesn't sound real. So because this is so good, she redid it, exactly the same data. The purple one, what you see here, the same thing actually. So two groups of animals receiving similar doses at two different tumor volumes showed exactly the same data, where singular introduction of this therapeutic nanoparticles within the tumor intratumorally showed no growth of the tumor or suppressed the tumor growth by 85 to 90% compared to the control group of animals. So this modality works not just with one phytochemical. This modality works with varieties of phytochemicals. If you're wondering what's going on there, as I had stated, tumors have this enhanced retention and permeation effect. It is not just the endocytosis based on tumor cell receptors. If you have nanoparticles of appropriate sizes, which we have, those sizes will also allow us to penetrate the tumor vasculature based on the EPR effect. That's how we enhance the retention of these therapeutic nanoparticles selectively within the tumor sites. And more examples of that. That's why we are seeing some spectacular efficacy. What you saw, because the tumor cells have this porosity, and the porous size is just appropriate for our gold nanoparticles, our therapeutic and diagnostic nanoparticles, to penetrate the tumor vasculature. And we have now developed a library of these radioactive nanoparticles, because we know one size doesn't fit all. That's why we have developed a library of these therapeutic radioactive nanoparticles with varieties of phytochemicals which have tumor cell specificity encapsulated around them, and we see spectacular uptake and retention of these nanoparticles within the tumor. And one of them that stands out clearly here is the mangiferin based nanoparticles. Of course, the EGCG is not bad. In fact, every single one of them, what you're seeing, can be used for treating varieties of tumors in human patients. This was what started us back in 2010, when we showed to the world that gamma arabic, which is a 45 kilodalton molecular weight protein naturally available from plants, when we encapsulated gamma arabic protein around radioactive nanoparticles, we had seen some spectacular efficacy. But then we wanted to make these nanoparticles tumor specific. That's why I discussed with you just a few minutes ago our ability to produce tumor specific nanoparticles using these phytochemicals. So what is the plan? We have completed synthesis. It is replicated in different laboratories across the world. We have done preclinical investigation in small animals. We have done toxicity in large animal, pig, why pig. The physiology of pigs mimics human physiology. Then we continue to do, although it is 2018, we still are recruiting animals, dogs with prostate cancer, because we can garner more and more data, and that data will help us to clinically translate our findings from preclinical investigations into human prostate cancer patients. Although I discussed a lot about prostate tumor therapy, these results, this technology, this modality is equally applicable for oral cancer, squamous carcinoma, for pancreatic cancer, as I said, for glioblastoma, varieties of tumors. We have done, treated dogs just like how one would treat a human patient. When a human patient is presented to a nuclear medicine doctor or a urologist with prostate cancer, we insert the needles, we understand the size of the tumor through ultrasound and the CT, then decide how many needles to be inserted based on the size, deliver the dose. We tell the patients, the dog's owners, to bring back their pets back to the clinic. Then we see the disease has stabilized or the tumor is completely treated. So if you're wondering what happens once the treatment is done, what is going to happen to those nanoparticles in the body? That's an extremely important question. You don't want too much of gold in the body. It can lead to gold toxicosis. So we have addressed that question through a 5-year investigation. We again use the dogs because the physiology and the pharmacokinetics, pharmacodynamics mimics human beings, and we have published this study not too long ago. Under the doses what we are able to administer to control or completely treat the tumor, with those doses we saw no systemic toxicity due to these gold nanoparticles. It's a great news, not just for us. For many of you, if you are using gold nanoparticles for tumor therapy applications, just follow this publication. As long as you keep the dose under the doses what we have discovered, you are fine. The human body will not respond negatively if we control the doses of these nanoparticles, which means this drug is ready for human administrations, which is something we have been working. I just want to summarize. With the EGCG, you saw spectacular therapeutic efficacy. With the mangiferin, the same story, which means that the problems that have existed right now for all of us, human prostate cancer patients, where brachyseeds are implanted mechanically, these mechanically implanted brachyseeds leads lots of problems, leads to a lot of toxic effects, and nanotechnology is about to solve all those problems, not just for prostate, for gynecological, for ophthalmic diseases, for skin diseases, and so on and so forth. So again, the current problem with the brachyseeds is that it leads to varieties of systemic toxic effects, brings down the quality of life of human patients. With nanotechnology, we have eliminated all those problems. We have seen no toxic effects one after the other. So it's not just one example, series of examples. Now we have a unified approach for using these nanoparticles to treating solid tumors, because we inject them into the tumor. Once the particles are within the tumor capsule, they kill everything within the tumor capsule. They kill cancer stem cells, which are kind of the machines for tumor growth. They kill mutated cancer cells. They kill malignant cancer cells. They basically destroy the tumor. They make the tumor, they destroy the tumor machinery. They stop that machinery from recruiting those tumor cells into the bone marrow. This is important because you might be wondering, look, we are administering this dose within the tumor intratumorally. By this approach, are we addressing the metastatic lesions? The answer is yes, because the metastatic tumor cells, where do they come from? They are recruited from the primary prostate tumor. If we can destroy the entire tumor cell machinery, there will be no tumor cells left to be recruited into the bone marrow. That's how we stop the metastasis. So it's a singular intratumoral therapy that allows us to completely decimate the primary tumor and stop the invasion and metastasis of the tumor to the rest of the body. So, what you have heard today is that any type of solid tumor, we have radioactive nanoparticulate therapy. Once the particles are injected, one could also use the non-radioactive analogs of gold nanoparticles. Radiotherapy does what it does very effectively, which you saw in my lecture today. The non-radioactive analogs open up new opportunities for treating tumor. One could use photothermal therapy, a publication, we published series of papers recently. One could use X-ray therapy. So, what I am trying to tell here, nanotechnology is not just about radioactive gold nanoparticles. That is one aspect, an extremely important aspect. Nanotechnology of gold in the context of tumor opens up other therapeutic modalities to work more effectively than they have done in the past. That is the future. That should make all of us optimistic as we get into this journey of using green nanotechnology for oncological applications. With that, I would like to thank lots of people. This is not a one-day work. It's not a two-day work. It has taken close to 3 decades to the point where we are now. Lots of people have contributed to this. I have bolted out Dr. Amal, one of our very best PhD students. There are lots of collaborators who brought different areas of their expertise, because nanotechnology is not just chemistry, physics, or biology. It brings in varieties of disciplines of science, engineering, medical sciences, and it disrupts those traditional boundaries. And that's why this is such a powerful field, especially when it comes to applying those principles to solving vexing medical problems. I thank our international collaborators, lots of them. I thank the funding agencies, lots of extramural funding. DNA is a company in India. They're marketing varieties of products under the name NanoLife. Our technology is licensed to that company. They will soon start conducting human clinical trials in different parts of the world. And I would like to thank all of you for your attention. If you have any questions, you can email me. You can talk to Dr. Amal. She will send me those emails. I will respond to those emails. I would like to thank 5,000, 6,000 miles away from here, and I wish the best of luck to all of you to this conference. And I want to assure and reassure to the organizers, to Amal and Dr. Irsa, I will be there with you when you conduct your conference the next time. Thank you. Thank you all.